I'm going to talk on something which is Indian because we see a lot of patients of hepatocellular carcinomas which are little advanced with portal vein involved. So, so we'll talk about the evidences, we'll talk about the level of evidences, but that is very important because this is something which is more of an Indian or Indian subcontinent group, and that we need our own data on that, and we are going to talk of our own evidences on that. What is the quality of SBRT? That is also very important. We always talk about the surgery and the quality of surgery, high volume centers, but many times we don't talk about the high volume center for SBRT as well, because that is also dependent on the usage of the machine and the volumes, what are the image qualities, and real-time tracking is used or not, and the toxicity and assessment of the response. Now, if we see the HCC BCLC staging system 2022, we see that actually there is no role of radiation in intermediate and advanced HCCs. So that is still has not come in 2022 as well. So most of the role of SBRT is in early stage HCCs where there is a failure after TACE or RFA, and but in advanced stage still there is not much clarity there. Now, if we divide the intermediate stage HCCs into early, means which are extended Milan criteria, intermediate, which is a multinodular disease, and extensive, which is involving the extensive part of the liver. Now, there is some role of SBRT in those situations, and we are going to talk about the evidences on that. And about the advanced stage is HCCs with portal vein involvement, there is some role of SBRT, and we are going to talk on that. Now, when we talk about the intermediate stage HCC, and from Indian and Indian subcontinent data, what you see, there are small studies from different part of this place, and most are retrospective and very small volumes, and it is the local control which is the main endpoint in these studies, not the survival advantage that has been shown with SBRT in this cohort. And there is a meta-analysis of of more than 300 odd patients, which has shown that TACE plus SBRT may be useful in this cohort of patients, which is intermediate stage, where TACE may not completely ablate, and a small portion of the patients which may have a residual disease, SBRT may be useful in that cohort. So SBRT alone may not have too much of role in this intermediate stage SBRT. So that is the post-TACE or post-RFA residual disease, the role of SBRT is there. Now, if we talk about the advanced stages HCCs, which is where the role of TACE is less, and surgery is most of the time not done. So that is where the role of SBRT is coming up, and we are going to talk about our experience on that. We have a phase 2 prospective database of 116 patients accrued in this study, and we have started in 2018 and prospectively accrued patients which are HCC with portal vein involved in a prospective setting in our institute. Now, since 2017 onwards, 300 odd patients were screened, and 200 odd patients were accrued, and 201 patients were delivered SBRT, and we have an analysis of 116 patients in this cohort, which are going to present now. Now, this is the format what we treat. We have a multidisciplinary tumor board. All the patients were discussed in the tumor board before we accrued the patients. Contrast CT scan is done in secondary state. Put the gold fiducials for tracking, and then we repeat the scan after 40 to 72 hours, and fuse it, and then do the treatment, and see the responders and non-responders at 8 to 12 weeks after the treatment is done. Now, we have, this is the cohort, and if you see, most of the patients are child A group, and if you see, most are BP3 and 4. These are mostly the main portal vein is involved in most of our patients, around 80% of our patients. And if you see the responders, 67 means 57% of the patients were responded after this radiation. So it is as good as most of the time you see that 40 to 60% is the response rate in the international cohorts, which is same in our patient population as well. Now, interestingly, if you see The mean overall survival is 12.8 months in our cohort of 116 patients. And you see the responders and non-responders. Responders mean OS is 15.9 months and non-responders is 8.8 months. So it is almost double the survival in those patients who are responders than the non-responders. We have tried to find out the, the to find out which are the group of patients from the patient characteristics, from the tumor characteristics to find out, but it was not possible because none of the patient-related factors or treatment-related factors were shown to be predictors for responders. And but child A patient, good performance status, patient with a portal vein involved, less 5 centimeter or less of the portal vein involved, they had responded much better, and female patients actually has responded better than the male patients. This is the response we see after the SBRT. And we have a group of patients which were eligible but didn't got accrued in the study because they have not given the consent. And there are group of patients who are non-eligible because of the poor performance status or metastatic disease. And we see the mean estimated overall survival is really interesting in this patient cohort. See, the responders mean overall survival is around 15.9 months, whereas eligible but not treated and treated TKIs patients were 5.6 months, and non-eligible patients were 2.8 months. So it shows that eligible patients but not treated with SBRT, they had a much poorer survival, and it can be considered as a control arm compared to the responders arm. It is very difficult to do a randomized study, but it may be the best case scenario where we have a control arm as well, apart from the responders. So we have the performance status. Patients who have a good performance status have a better survival than the non-responders. Patients who have a complete resolution have a much better survival than compared to the patients who have a bland thrombus. So the type of response also is a predictor for the survival functions in this patient cohort. We have seen all the different patient treatment parameters available in portal vein thrombosis, and you see that that most of the time the toxicity and the survival is almost similar, but the toxicity at SBRT is much lesser, 5.2% of radiation-induced liver disease in our patient cohort, and 19% non-classic radiation-induced liver disease in our cohort, which is around usually 14 to 20% in the standard cohort or SBRT treated with liver disease, which has seen. Now we put fiducials, and fiducials has its own issue. So we have a scoring system to find out the quality of fiducial placement. That is important. It is the clinical parameters and the and physical parameters, where the minimum distance between the two fiducials and how many fiducials are put, and any clinical effects, means patient have unexpected events or happened or not. Accordingly, we can actually have a scoring system. We have seen the radiological scores are there. 20% of the patients do have some kind of migrations, and that need to be taken into account. There are sometimes the fiducial placements are done like that, and there are some unusual presentations, and there can be migrations. Like in this patient, we can see the fiducial has migrated into the pelvis, and there are different methods. Like it can go to transcoelomic spread to the pelvis sometimes. It can go to the main portal vein and get into the intestine, or to the hepatic sinusoids, and can go to the lung as well, or heart as well. It is rare, but this is a complication that needs to be taken into account, and fiducial placement has to be done in a controlled setting. And in toxicity criteria, there are classic radiation-induced liver disease and non-classic radiation-induced liver disease, which actually happens in different time frame, and that need to be accounted when we do SBRT. Usually the standard, if you see all the articles, and the toxicities and radiation liver disease around 14 to 20% in all the cohorts which have been in the Western literature is there. So in our patient cohort also it is almost similar things. So the recommendations are, in preserved liver function, child up to B7 with good performance status, SBRT to the portal vein actually can be useful. It is still there is some retrospective and series and some prospective database, as I showed. And endpoint is responding the portal vein, and if there is a response to the portal vein, recanalization happens. then the decompensation to the liver actually is delayed, which may have an impact on improving the survival as well. So, so these are the recommendations if in a early stage disease, in early or intermediate stage disease, and if it's a good performance status patient, good child, and not refusal for the surgery, they may be a candidate. For portal vein thrombosis patients, as the endpoint is survival advantage, and there is a level 2A evidences in that, and there is a prosperity database in our patient population as well. So when we talk about SBRT, we always need to talk about the modality of SBRT which has been done, because it has to be a fiducial tracking base which actually gives a better quality of radiation, and the volume need to be done under triple phase CT scan, and what are the margins need to be given, and the dose constraints which are given, and the and how the toxicity assessment is done. Many times we do the toxicity assessment as per the child book score changes. 2 score or more changes are considered as a definitive, definitive response assessment and toxicity assessment criteria. Thank you.